everybody. Thank you for coming this morning. My name is Marty Dorgan, and I'm the Vice President of Quality and Safety, and sort of the Ebola czar right now. A nice new title to have. And with me today is Tammy Cooper, infection. Am I on? I'm not on.
Did you push the button?
And with me is Tammy Cooper, infection prevention nurse, and behind me are my marketing friends, Casey Duffy and Blake Long, and they've been helping me, helping us get ready and prepared for Ebola. So we'll start out with how is Ebola spread? It is spread with direct contact between body fluids and broken skin and mucous membranes, blood, vomit, stool, urine, semen, breast milk. A person is not infectious until they develop a fever, and the incubation period is 2 to 21 days. So if you meet someone and they have been to Africa and they do not have a fever, they are not contagious. It's as simple as that, but it's very hard to understand that sometimes because we live with fear Ebola and we're quite afraid of this virus. The symptoms are very much like flu symptoms, which makes it somewhat complicated to diagnose. Fever, abdominal pain, aches and pains, diarrhea, headache, fatigue, all of those are just like the flu symptoms as we enter flu season. That's why it is so important to ask those travel questions. We're asking in the hospital at every port of entry, have you traveled outside of the United States, and where have you traveled? And if it's in those countries and someone has a fever, we would believe them to be high risk for the Ebola virus. Many misconceptions. A myth, Ebola is airborne. Ebola is not airborne. As I just explained, it is only through the mucous membranes. Body fluid of a person who is sick or has died from Ebola. Objects that have been infected, such as a syringe or needle, and then animals that are infected. It is believed that the bats were the first to get Ebola, and then they infected a monkey, and someone did an autopsy on a monkey, and that's where the spread of Ebola has started. Other common misconceptions is that Ebola is impossible to kill. Ebola is easier to kill than C. diff, and we know that C. diff is a common infection in our hospitals. If you're concerned about Ebola on the surface, if you use Cavicide or Oxivir, which is what we use in our hospitals, wipe it off and wait the dry time, 3 minutes for Cavicide, 1 minute for Oxivir, the Ebola virus will die. It has been said if you don't wipe it off, you can live for 4 hours to
anywhere from 6 hours to 6 days, depending on the environment and weeks.
So I take this opportunity to think about, this is our time to clean up our infection prevention habits. There's no time like the present to be wiping off our phones, wiping off our surfaces, wiping off doorknobs, things that we have been teaching ourselves and trying to hardwire in hospitals for years. So to start doing this, not because we might get Ebola, but now is a good time to have that heightened awareness and to clean your workspaces every day, clean your doorknobs, wash your hands, follow your isolation procedures for any patient in the hospital. This is the time to do it. It's on the news. People are watching us as healthcare providers, and we need to protect ourselves, each other, and the general public from any messages, the flu, or more intense cases like Ebola. So where are the Ebola cases? Ebola is in 3 countries in Africa. It is in Sierra Leone, Guinea, and Liberia. It was in Nigeria, and I want to talk about that a little bit. Nigeria is a country that does not have the hospital beds that the United States has. It does not have the technology that the United States does. It does not have the supplies regarding medications and treatment, as well as PPE equipment. And they were able to capture and control the spread of Ebola, and it's no longer a high-risk country. So if Nigeria could do it, certainly the United States can do it with all that we have, all the richness in healthcare supplies, technology, and knowledge, and hospital beds. So a reality check. As of, October 7th, 13 people died of Ebola every day. You look at these numbers, these are daily numbers of people in Africa. 110 died from tuberculosis, 404 from diarrhea, malaria, 552, and HIV/AIDS. 685 people die every day in Africa for that. So when you look at that, you can see that we would want to control Ebola. It does have a 90% fatality However, we do not want it to reach that capacity of these other bad viruses and diseases. So Ebola in the United States, 4 healthcare workers got nosocomial transmission from West Africa. 1 Liberian national, Mr. Duncan, who died in Dallas, and 2 nurses in Dallas. Now we have a 3rd doctor since that slide went up. 1 anonymous person and 1 media cameraman. 6 out of 9 cases were from nosocomial transmission with a case fatality rate of 11%. The United States is doing very well. In Africa, the death rate is 90%. And one of those reasons are people are so poor in Africa. If someone dies of Ebola, we learned this from one of our doctors, someone dies from Ebola, they cannot get rid of that extra mattress that that person had, that extra pillow, their dishes, whatever. They cannot, they look at that as a gift. They may go down to the river that is very infected with Ebola and everything else and clean it. But that's another reason why the spread is so bad and so hard to contain. Plus, there are no hospitals in Ebola, or if they do have hospitals in Africa, there's no water. Dr. Kerrigan is going to Africa next year, and the hospital he has does not have any water. So you can see the challenges that Africa faces. So when we were tasked with how are we going to manage Ebola at Unity Point Health in Peoria, it was a big task, and there's so many things to do that we put together a team and we set our priorities. And as you can see from the team, we have Tony Howard, who is the emergency director at both campuses. Our 2 infection control nurses, Tammy and Deb Steele, Maggie Ballard, EMS, Tony Jorgensen, nurse manager, Lathan Casey from marketing, and then myself leading it. We also have 4 other executives who support us, who help us when we're struggling with making a decision, or when we have 2 ways of looking at something, they also weigh in. So it's very executive-driven as well as employee-driven, how we were going to master and prepare for cases should they show up in Peoria. So then we asked, are we prepared? What have we done to prepare? What have we done to make you feel safe, the community feel safe, but still care for our patients? Tammy and Deb Steele started working on Ebola protocols in August. This is when they started thinking this is a threat to the United States. We need to be prepared. So they had started working on policies and protocols without much attention from any of us about that. Then the case in Dallas came, and everyone got involved, and we knew we had to step up our proactiveness of being prepared. So multiple protocols. How many of you have seen them on Connect Me? So those of you who have not used Connect Me, there's a wealth of information on there in our preparedness plans. We have executed drills in the emergency departments to test our protocols. Every time we do a drill, we find something that did not work well, or that we needed to make a little bit safer, or we needed to do more research. Drills are so important, as well as having the education and knowledge in this area. We're working to schedule other areas for drills. This week we did the lab. So we had 2 lab employees pretend that we had a patient in the ED, and they practiced how to draw the specimen, how to package the specimen, and what to do with the specimen. One of them read the directions that we had outlined, and the other one did the actual procedure. And they found some opportunities for improvement. But what a great drill, what a great practice run that was. So what is our plan when a patient comes? We will not keep Ebola patient here long term. What we're seeing across the country is as soon as we have a diagnosis, they are moving to a center of excellence for infection prevention. We have 4 hospitals in Chicago that have been designated, but that does not mean our patient would go there. It would be up to the CDC to guide us, probably based on the patient's symptoms, where that patient will go. We are working with SWAT teams. Now you've heard, if you've seen on Connect Me, we're asking for volunteers of SWAT teams. And what does that mean for a SWAT team? It means a couple of things. The first line of defense for a SWAT team is, let's pretend a patient comes into one of our clinics. They say, I have traveled to one of these countries in the last 21 days and I have a fever. So that is very concerning, and you are at risk of having this patient be an Ebola patient. So they have a protocol the clinics do, and they're practicing it on what to do should that happen. One of the things that they would do then is immediately call the administrator on call, and members of the SWAT team, which today might be Tammy and I, would go to that clinic to help with the transfer to which hospital was take care of the PPE equipment that was used to really lighten the load for the clinic people. We would work with the EMS system as far as which ambulance would transport that patient. All of those things are part of that role of the SWAT team. The other role of the SWAT team is that we are asking for people to care for these patients. These patients are a vulnerable population. We have learned how to protect ourselves. We learned a lot from Dallas. And we're asking people to volunteer to care for these patients without having to just assign people. If we don't get enough volunteers, then it will be, our job is to care for these patients. And we do have multiple volunteers, and we're getting more and more every day. We have 5 doctors and several nurses, lab, 5 respiratory therapists, chaplains, so people have stepped up. But I encourage all of you to also step up and think about helping on these teams. So areas to perform pre-screenings. Any port of entry. If you're not up here, that doesn't mean you don't ask those questions. Have you traveled outside of the United States? And if the answer is yes, and it has been to those countries, we would. There's a process for taking temperature. But any area coming in is where you would ask those. Protecting our employees at point of entrance. We have buttons that we've ordered, and they say, have you traveled outside the country? Our valets and security people will be wearing them. A point of interest last week, we had a patient come in who had traveled outside of the country, not in those 3 countries that I mentioned in Africa, but they had traveled, they had a fever. It was just a little unnerving for the emergency department at Proctor. But we learned that the process worked. The first person that met them was security. He came back and got the charge was in the ED. They put the patient in isolation, not the full PPE, because he did not meet the criteria of traveling to those African countries. But we did learn that security asked the question and it worked in the case of the patient. So that was a live drill and worked very well, so we're very pleased about that. Protecting the employees with PPE. So we have followed and surpassed the CDC guidelines before they set full body screen. 2 weeks ago, Monday, we started training the ED. Did any of you see that on the news? We had all the news people here, the newspaper, and we practiced with our emergency room employees. And it's a 2-man practice. It has to be 2 people, one to help them put it on and one to help them take it off. Your risk of contamination is greater in removing your PPE equipment. So we have trained people to help to be the spotter or the partner, to help watch as they remove, to help follow the guidelines as they remove the equipment. And we practiced that until we heard the nurses say, I feel safe. When they came down to train, they were cautious and a little bit resistant, and when they left, they said, wow, I really feel safe. So that was a very successful day for me, because our goal is to keep everybody feeling safe. We have kids made up for the clinics and kids made up for the ED. We trained 70 infection prevention liaisons from the clinics, and they have gone out and it's trained the trainer. We met with the directors yesterday to execute drills in the clinic. What do you do if a patient comes in? We take time a patient, then we watch you put your PPE equipment on. We wanted to step up increased intensity in practicing in the clinics as well as the ED. We have, each clinic has 5 kits of PPE equipment. We've done a lot to prepare and order supplies and have best practices, as well as exceed the CDC guidelines. 2 high-risk areas we identified, which I've already spoke to, and that was the ED and the clinics. Where is the risk of, potential risk of a patient coming in, and that's those areas. And I've spoken to all that. Much training and support materials on Connect Me. You have a video that has been developed with our employees. You have outlines, you have education, you have protocols, you have scenarios. So there's multiple ways to educate yourself and feel secure about Ebola and what your role is. I talked about the SWAT teams. I always jump a little ahead with that. But I do ask that you consider how you can help should a patient come here. Talk about the PPE. I've done this so much, I think I don't need the slides anymore. And then it takes a community. We're working closely with the community. There are no secrets with Ebola. There are no secrets between OSF and Unity Point. We want as much like protocols as possible, like policies as possible, like ideas as possible, all based on the CDC guidelines. We've had a community meeting with OSF, Unity Point, Public Health, Fire, EMS. Walgreens, because patients walk into Walgreens to screen. It's very interesting. And we shared what we were doing, we learned what we were doing, we identified opportunities for us. One opportunity would be an example, in a rural area, there may be one ambulance. Do we really want to put an Ebola patient in the only ambulance in a rural community? That takes the ambulance away from anybody that could be having a heart attack or stroke. So we are currently working with EMS with our EMS system to identify one ambulance, strip down the supplies that would transport that patient. That's why we don't want the rural clinics calling 911. We want them to call the SWAT team so that we can attempt to assure that we are protecting the community in that sense. We also have, and I didn't mention, Unity Point at the system level has a very large Ebola team, and they review our materials, we review theirs. They help set protocols for people who maybe haven't done as much as we have. And it's great to have that reassurance that they are assuring that we have the supplies, that they're one step ahead. Should there be a shortage of supplies, that we're prepared. So it's great to have that community. And then one Gandhi says, the best way to find yourself is to lose yourself in the service of others. And this is really a vulnerable population, and it is not limited to just the poor. We see healthcare workers are the number one people who are being affected in the United States, and we are all here for our patients, so it's a time to do some soul searching there. That's my presentation, and now I'll take any questions that you have. Yes?
We have several patients that get confused as to where our emergency room entrance is, and they walk into the main lobby. There are concerns that an Ebola patient would come in there, and immediately everybody would be vulnerable to that patient, trying to get them to where they need to be.
So the question was, when patients walk through the main lobby, what do we do? And Tammy, you've done a lot of work with this.
Right. There's signage, as everybody has seen, and you saw up there the blue sign that talks about if you've seen, been addressed. And the people at the information desk have been instructed, anybody who comes up there and is asking for directions, they're, especially if they're asking for the emergency room, they're gonna ask that question. If we do get somebody who comes into either hospital's registration area, their front entrance, and they say, yes, I do have that positive travel history, and even if they say, no, I'm not feeling bad, I'm just looking for the ultrasound department for a scheduled appointment, we have a protocol in place that during the day, Monday through Friday, normal business hours, on this campus, they would call Deb Steele, on my campus at Proctor, they would call me. We come down, they would mask the patient and mask themselves, and ask the patient to put their hands to their sides and their pockets, not to touch anything. We would then come down and take their temperature, and we've ordered no-touch forehead scanning thermometers, which should be here hopefully in a couple days. We'll take their temperature. If they don't have a temperature, then they're a regular old patient. We unmask them. They go about wherever they need to go. We'd escort them to the ED if that's what they were looking for. If they were to have a temperature, then we would at that time take them back out the main entrance and around to the ambulance bay, so we're not going through the hospital and possibly touching anyone else. And someone in registration or at that front entrance would then call the ED and say, the infection control nurse is bringing around a patient that has that history, has a temperature, it's a possible Ebola patient, so they can go ahead and get their PPE on. We would stand outside in the ambulance bay until they come out and get us when they were in full garb, so they don't potentially expose themselves. If after hours, nights, weekends, holidays, obviously we're not here 24/7, thank goodness.
It feels like it though.
Yeah. It would be the emergency room nurse. The director of emergency services, Tony Howard, has let his ED staff know that if they get that call, after hours and we're not here, the registration or front desk information calls and says, I've got that patient, and it's after hours. They know they have to stop what they're doing. A person has to grab that thermometer, come out and get that temp, and do the same process as we would do. So it has been looked at and put into place because, they can walk into any door.
Yeah.
Is that posted on the next page?
Yeah, it's on the registration entry protocol, the ports and entry protocols.
So all of you should be reading all of those connecting protocols.
Right.
You will learn from that, and you will feel reassuring that there's some guidelines to follow. Other questions? Yes.
Clinic,
Uh-huh.
positive, or we don't know positive Ebola patient comes in, waiting room is full. Do we get locked down? No one in, no one out, or can people then come and go?
We don't want to lock it down. If your patient walks up to the desk and says, yeah, I've been here and I'm not feeling good, they look like death warmed over, and you just tell this person is sick. The process is the same, whether they don't look sick or they do, for the first couple steps. The front desk person obviously is not a clinical person, not an LPN or an MOA or an RN. Their job at that point is to, call back and let them know we've got a potentially Ebola patient with positive history. you drop them a mask, and whoever's with them, they mask. While they're doing that and showing the patient how to put that mask on, of course, without touching them, the person in the back is donning their full clinical PPE. They are then going to come out, but that patient during that time is going to be asked by the front desk person, again, hands at your sides or in your pockets, no touching, no sitting. Then at that point, the staff member will bring them back. They've all got a designated room, which is the most out of the way, with no cloth furniture, no curtains. It's been stripped of all stock supplies, because everything in it has to be destroyed if that patient turns out to be an Ebola patient. And then at that point, they get them in that room and they say, you know, they find out what country they've been to, when they came back to the US, because if they're outside that 21-day window, even if they were in Liberia and now they have 103 fever, if it's been 26 days, it's not an Ebola patient. So they can, you know, kind of whittle it down. But if it's been in that 21 days, those 3 countries, and they have a fever, at that point, they're going to tell that patient, you know, we do see you as a potentially Ebola patient, and more than likely these people obviously are going to know that as well. Everybody's hearing it and everybody's seeing it, especially if they were there. They're then going to tell them that they're going to go out and contact the administrator for the hospital. They have to stay in that room and keep their mask on until someone else comes back in. They're going to remove their PPE in the way that it's outlined, back out of the room, shut the door, put an MDRO sign on there, alert all staff that no one can go in that room, and then the SWAT team will be sent to that location and we'll handle it from
But
there.
what about the patients that are in the waiting room?
patients in that room?
Are waiting to see the physician?
Right.
They can freely come and go.
Yes.
They're going to be in a state of panic.
And if they choose to leave, they can. I'm assuming that's what we're gonna see will happen more than likely. And what we've instructed our clinical staff is to let them know that we are looking at a possible infection. We're not gonna say Ebola because we don't know. And we don't want that stigma attached to that patient. Will those other patients assume that? Possibly, and we can't help that. But we will record all patients who were in that waiting room at the time on our log sheet so that our potential contacts for the health department, the clinics all have a sheet to fill out as well. And while that other person is rooming this one, another staff member has to don their full PPE and immediately go out and disinfect every surface they can find, the outside of the entry door coming in, anything that patient might have touched. If they sat down in a chair, there's a protocol to address that, cover it with a red bag, and move it to a designated location for staff to come, EDS manager Rob Folk to come and collect. Because again, if it is Ebola, it would have to be destroyed. Now, as far as the lockdown, if you have a patient who walks in, and hopefully they wouldn't go to an outpatient clinic, but you know, sometimes patients see those as the same as an ED. So you have a patient who walks in and they walk up to the desk and I have a positive travel history and they start puking all over your floor.
That's a whole
And that's when, at that point, yes, I would ask everybody to leave the waiting room because you should have them already on your sign-in sheet, so you don't need to collect their names, ask them to leave, and then yes, I would lock the door behind them. Because at that point, you've got obviously a high viral load if it is Ebola, and it's uncontrolled. So we don't want any potential exposures at that time. But just a regular patient who walks in not feeling good, they're fine to stay. And if they choose to leave, we can't help it.
And Ebola is spread by the viral load. So somebody who is low-grade fever, needs that travel history, their viral load is very low, and their contamination risk is very low. So we have to remember the common sense here,
Right.
although it is fearful. What happened in Dallas was his viral load was so high, and he was essentially bleeding from everywhere in his body, and that increased the risk. It was our first case. Our PPE maybe was not as good as it should have been, and that high viral load, we don't know. We've not seen that high viral load again in the United States, so we really don't know about that. That was a one-time case here in the United States. We know that when the doctor and the nurse first came back from Africa, they were very ill, but again, they did not have that highest viral load where it's essentially Ebola is eating your body from the inside out. That's what happens. So, yes.
The second question I wanted to ask, the person that's gowned the whole thing, they went into the room with the patient. Now, does he or she have to go into isolation for the 21 days?
No.
Okay. Do they have to leave work for a certain amount of time because they were exposed?
No,
No.
because
Okay.
they are not contagious until they have fever.
Okay, so life goes on
Life goes
until
on.
they show
We would
symptoms.
report that to our employee health,
Mhm.
and we would ask that they took their fever, their temperature twice a day, I think.
Morning,
Yeah.
night.
And we would check in with them every day, but life goes on, you are not contagious until you have been exposed to someone, until you have a fever, you are not contagious.
Okay.
Yes.
I have a couple
That's fine.
Is there a specific SWAT telephone?
Administrator on call, and that's in your protocols.
Okay.
So you just have to call any hospital operator, and in the protocol is written both hospital mainline numbers in case somebody doesn't know one or the other. Just operator picks up, this is so-and-so location, I need the administrator on call page. She'll page right back to your location, make sure somebody's ready right there to answer the phone. Tell them what you've got. She'll ask further questions and kind of delve in to see, does it really meet this travel criteria, or are we outside the window? And they just want reassurance, which is totally fine. I would too if I was in that situation, that we're safe to treat it as a regular patient. And if it is a SWAT or an actual potentially Ebola patient, the administrator on call after she hangs up with you from gathering information will contact us and we'll be dispatched to that location. But we will be, if you're in an outer area, there's been concern about some of our clinics are as far away as Canton and Lincoln. So you've got, half hour, 45-minute drive time. We will be in contact via phone that entire time in case the condition starts to change, which it shouldn't. These patients should, again, hopefully be in a very early stage, just not feeling good. So again, it should not be an emergent, this patient's crashing right in front of me type of situation.
My next question is, how are the airlines disinfecting, like, the inside of the airplane?
Supposedly, well, I cannot speak to that, but my son is a pilot and I'm flying with him tomorrow, so I will let you know.
Okay.
But they certainly have increased. I know that, I know from a pilot's perspective, they get emails every day on do's and don'ts, precautions, and they're well on the pilot side equipped. And I know from an EVS perspective, they have stepped up their cleaning, but I can't speak to that.
And the airlines, the government did mandate that all flights that originate from Africa have to be sent to the United States, their final destination must be one of the 5 designated airports that are doing all the screening. Before it was 95%, so you had little tricklers. They've mandated those flight routes have to be changed. They have to land in the U.S. in one of those entry ports.
So, but, like, if they do have a positive patient
On the plane.
on the plane, how are they, like, disinfecting those?
That, I don't know how
I
they're
can't speak to
disinfecting.
that, but I
But
do know
again-
that they have put out,
Right.
aviation is, I want to say as on top of it as we are, and we're not 100%, but we're really working hard.
But I do know that, they've had a couple instances, and you probably heard about the stewardesses who locked that one woman who was vomiting on the plane in the lavatory throughout the entire flight because they were worried. And, they have their own version of a hazmat or SWAT team that comes, collects the patient, takes them off in a secure fashion. But what they do to disinfect the actual plane, I'm not sure. But again, if it's not blood or body fluid that's been put on anything, it should not be infectious because there's nothing that's been, put out there by that infected patient to possibly infect someone else. But I don't know what their process is.
Are you flying?
I'm not, I've never flown, actually.
Okay.
I just had somebody ask me to ask the question, so.
Well, it's a good question.
Any other?
Yes.
I do, actually.
Okay, go ahead.
My husband works for the sanitary district, in the sewer department, and I just questioned myself, is he potentially at risk? Okay.
We have you want to explain that?
Yeah, if a patient uses the toilet, okay, they're vomiting, they have diarrhea, the process that will happen is you will put a bleach solution in the toilet, you wait a minute to flush it, then you flush it. Because when you flush a toilet, I'm sure everybody kind of knows, little mist comes out, aerosolizes, that way that bleach is in there, it's deactivated any virus that was expelled by that patient before it's flushed. So what's aerosolized is nothing other than what was, materially in there in water, so.
And then there's a company that hauls the waste away, a separate company that has to be contracted. We have a special dumpster ordered for Ebola waste, and then some special team comes in and manages that. So it doesn't just go out of the hospital garbage. Yes, question?
Well, I was just thinking about the water supply in general, but they're treating it on the water treatment side.
Right.
Other questions? Yes.
Once you've got that patient in there, the clinic personnel does not have to stay in that room, right? You're supposed to leave and just get up with the back. How are you going to monitor the patient's progress if you're not in the room?
You can talk to them through the door and that's it. And unfortunately, and luckily, luckily the CDC has put it out there that, this is not just, run-of-the-mill MRSA or something, not that that's something to be looking at lightly either, but this is Ebola, and our first priority is to protect ourselves. And they have said, we've heard questions that, it takes 5 minutes to put on this PPE, and what if that patient is standing there puking while I'm doing this and I can't help them because it's healthcare workers? We want to be right there, we want to fix them, and, we'll wash our hands later if it's that type of emergency situation. not with this. If it changes the outcome of that patient, unfortunately, for you to put on your PPE